Well, it's good seeing you guys out there. Sorry it has to be remotely. I have such fear of missing out now that I see everyone hanging out without me. So I look forward to hopefully being there in person next year. I did want to take this opportunity to speak today specifically on the endoscopic posterior cervical foraminotomy and discectomy, which has become one of my favorite surgeries in all of spine surgery. I think, like many people, I started doing endoscopic surgery, focused on the lumbar spine, thinking about it as a discectomy tool. But rapidly, I found that it's a really powerful and elegant way to address cervical pathology, and has become really a common way that I address, especially radiculopathy in the cervical spine. So what are the benefits of endoscopic cervical foraminotomy? A lot of the similar benefits that you get in the lumbar spine. Obviously, less soft tissue disruption, given just the narrow aspect or the narrow, working cannula and camera. That allows for more rapid recovery, as we all know. The other nice thing is that the fluid pressure acts as your friend. So it tamponades the epidural venous plexus, which anyone who's done an open or tubular cervical foraminotomy knows can be annoying. It's not a clinically significant amount of bleeding, but that amount of bleeding can obscure visualization and make the procedure more technically demanding. The angled optics also provide improved visualization. So one of my favorite things is at the end of an endoscopic cervical foraminotomy to actually rotate the scope 180 degrees, and you get this incredible out-of-body experience of looking back toward yourself out the foramen. And I feel like I can much better evaluate the adequacy of my decompression because of that. And I'll show some video and some video later on in the presentation just demonstrating that. And then, a lot of these things are, marginally better as far as recovery goes and things like that compared to other techniques. But actually, with the endoscope, I feel like you can actually do a better foraminotomy. And there is evidence to support this. So Kim et al. Published this really nice study where they compared tubular versus endoscopic posterior cervical foraminotomy. And what they found was that with the endoscope, you could get just as adequate of a foraminal expansion, but you don't have to resect as much facet joint. And the reason for that is with the endoscope, you can drop your hand more medial to work in a more medial to lateral trajectory and better undercut that SAP. So you can really open up the undersurface of that foramen, opening up the foramen without having to take as much facet joint, which I think likely has implications for any subsequent issues with post-op instability, et cetera. And then, the studies show that there's equivalent or superior clinical outcomes with endoscopic versus other techniques for this, yet there's shorter length of stay and less post-operative neck pain. Dr. Hofstetter had mentioned the ESRG and the work we're doing to collect and publish data. I think that we're nowhere unless we're publishing our outcomes and learning from them. What you see on the right is a screenshot from a phone app that Dr. Hofstetter has really championed called Spine Healthy, where we're really getting very granular data on these patients. The typical follow-up, you do the surgery, maybe you don't hear from the patient for 2 weeks or 6 weeks. And we only see them in these chunks. And one of the beauties of endoscopy is, patients bounce back so much faster. And unless we're capturing more granular data, we're going to miss that first 2 weeks where really there's a huge amount of benefit to these endoscopic procedures. So this is some of the data on one of my patients, one of my endoscopic cervical foraminotomy patients. What you can see is preoperatively pretty severe left arm pain, radiculopathy. Every single day afterwards, we collect this data. And so even on post-op day 0, you can see that arm pain went down to 0 and was essentially sustained out into, the future. A little bit of neck pain in the post-op day 0, post-op day 1 time point, which also rapidly tailed off and went away. And so what we can see is, we're not just seeing 2 weeks later, they're doing great. We're seeing that, 1 day later, they're doing great. 2 days later, they're doing great. And they're getting back to their activity. So this is their step count down here. And you can see within a few days, they were walking a lot more than they were before. These on the left are some of my statistics that Dr. Hofstetter and I published, and I'll come back to this, but my average length of stay for one of these endoscopic cervical foraminotomies is about 140 minutes. My average arm pain goes from a VAS of 5 down to about 1, neck pain down to less than 1, and then the NDI from about 32 to 15. And that 15 number is actually very similar to what's seen in the long-term follow-up for like the cervical IDE study. So you see, we're really able to help these patients get back to the things that they want to do. As far as indications for an endoscopic foraminotomy, you know, the most straightforward ones are people with single level, unilateral, isolated foraminal stenosis, either due to spondylosis and or a disc herniation causing monoradiculopathy. Probably the easiest ones actually are the stenosis, not the disc herniation ones, because once you unroof the foramen, you're pretty much done. For a disc herniation, you've got to do that, and then you've got to retract and reach around under the nerve and extract the disc herniation. But really focusing on one level, one side disease without substantial central stenosis is a good starting point. Similar to any other way you do this, if they have instability, significant spondylolisthesis, a lot of kyphosis, you know, this is probably not the best operation, but those are really the minority of patients. I do not find that substantial disc degeneration and up-down collapse, substantial ventral pathology, or weakness or contraindications to this. And I've had success in patients with all of these things. I do think that bilateral and multi-level cases are feasible once you get an operative efficiency, but you know, you're a little bit slower when you first start. And so I think that biting off something like a multi-level or a bilateral is probably not the first thing that you want to do. Operating room setup. So I have the patients prone on 4 posts. I keep the arms on arm boards down by their sides. I find that putting their arms down like this on the arm boards rather than wrapping them up in the sheet allows their shoulders to fall ventrally a little bit and improves my visualization on the lateral x-ray. I tape the shoulders down just very gently. I don't use any sort of cranial traction. I just put their face down on a head holder. The head holder that I use is adjustable. And so I can put them into a little bit of flexion that helps, you know, open up the posterior elements of the spine. But I do not find that any sort of, you know, cranial traction is necessary. As far as the setup goes in the room, it's very similar to any lumbar case. So you're standing on the same side as the pathology with the scrub tech and the instrument table, anesthesia up top. I leave the C-arm in and have it just slide north once I'm, you know, where I need to be in operating. So you can easily slide it back down into place if you need it. And then the endoscopic screen and tower directly across from you. I use a 15-degree interlaminar endoscope, the same exact scope I use for my lumbar cases, and find that this is very effective. As far as pump settings go, I keep the pressure on my pump at about 45, which is similar to what I do for my lumbar cases. I do increase the level. So my lumbar cases, the level is about 45. My cervical cases, because I have them in a little bit of, you know, reverse Trendelenburg, their head's actually a little bit higher. So I keep that up to 85. And I have not had any sort of issues with, you know, increased, you know, pressure as a result of that causing any sort of symptoms. So let's go through a case during which I'm also going to speak through the technique here. And then I believe that Osama is going to, you know, work through one of these with you guys in the lab. So this was a patient that was referred to me, a 44-year-old male with acute left-sided C8 radicular type pain, as well as weakness. And, you know, as you can see, he has no significant coronal or sagittal plane deformity. His problem is down here at C7T1. And what he had was a left-sided disc herniation that was, you know, impinging upon the exiting C8 nerve root there. Difficult to access through an anterior approach, which is what many spine surgeons are most comfortable approaching the neck in. And so it was referred to me to see if I could do something posteriorly and specifically with the endoscope. And obviously the answer is yes, or we wouldn't be talking about this today. So what I indicated the patient for was a left-sided posterior cervical foraminotomy and discectomy at this C7T1 level. So just to talk through the technique, I position the patient just like we talked about. The first thing that you need to do is localization. Oftentimes in the lower cervical spine and at the cervical thoracic junction, you're not going to see much on the lateral x-ray. So I do most of my localization on the AP. What you're going to want to do is get a good end plate view of that disc level. So here, the patient's prone. So this is the left side. This is C7. This is T1. And what I actually do is I make a mark. I mark the midline. And then I mark the medial aspect of the pedicles on the side of the approach. I make these vertical lines, and then I make a horizontal line across basically the disc space. And my incision, I make a little vertical incision, 8 millimeters or so, right where that horizontal disc space line meets that medial pedicular line. And if you start there and you work straight down, you're basically going to find yourself right at the medial aspect of the lateral mass, which is where your decompression is going to start. So I inject local, I make my incision with a knife. You do need to cut all the way through fascia. And oftentimes I'll do this with periodic lateral x-rays just to make sure that my knife is deep to the supraspinous ligament or the top of the spinous processes. And I know that I'm through fascia. Then I just take the dilators and I put the first blunt dilator down right onto that medial border of the lateral mass. And that's really what I'm trying to feel, and specifically where the IAP overlaps the SAP below it. That interface is a good place to feel. Then I dilate up and I put my working channel down and take an x-ray. So that's this AP here. This is just the tine of the cannula here, but the actual cannula in the spine is right here, right at the medial aspect of the facet joint. And then I take a lateral. In the upper and mid cervical spine, you can often see my goal is just to be in line with the disc space, pointing at the correct disc space. Lower, cervical thoracic junction, harder to see on the lateral. So this is what you see when you put your scope down, and this is what you're looking for. So your bony landmark is this interlaminar V or interlaminar Y, depending on what you want to call it. And really from this point on, the surgery that you're doing is really the identical surgery to if you were doing this through a tube or open or any other way. And the steps are the same. We're just doing it in a more elegant manner. So what you're going to see here, this is what you see, this on the left is just a schematic of the spine. On the left is cranial, on the right is caudal. And this circle here is what we're looking at through our endoscopic working channel, this is, again, it's a left C7T1. This is the caudal aspect of the left C7 lamina coming into the inferior articular process. This is the cranial aspect of the T1 lamina. And then underneath here is going to be the SAP of T1. And then the joint is right here. And then in here is going to be the interlaminar window with ligamentum. And so what I do is I just clean off the bone just at this interface here to give me bony landmarks. You can feel with a blunt probe that it's soft in this area up here, and you know that you're starting at the right spot. I like, if you're going to err toward taking more bone, you'd rather start a little bit more medially than laterally, because ultimately you don't want to take too much of the facet joint. Basically, you want to take less than 50% of the facet joint. And really what you want to do is unroof the foramen from the pedicle below to the pedicle above and out to the lateral aspects of the pedicle. So that's the definition of the foramen. And if you've done that, you've opened it up dorsally throughout the entire foramen. So what I do next is I take a diamond burr. I use the coarse 4.5 millimeter diamond burr, which is very safe. And you can burr in very close proximity to the neural elements without, having an issue here. It's not the fastest burr, but fortunately, in these cases, you don't need to remove a lot of bone. So I find that it's more than sufficient to do this. Down at C7T1, especially in males or larger patients, sometimes it is a little bit more bone, but I find that this burr is more than sufficient in order to accomplish the job. So what I do is I start by thinning down the IAP and a little bit of the lamina of the level above. And you can burr all the way down until you get to the SAP below. Sometimes I'll just I'll thin it out and take a kerrison. That's what you can see here, just removing that last bit of the IAP of C7. And once you've done that, underneath it, what you're going to find is the superior articular process of T1 in this case. And that's what you can see here. I'm just kind of using the working cannula and the tine of the cannula to kind of push a little bit. And you can see that I've removed that IAP all the way down to the cranial aspect of the superior articular process. And that's a really important point, because if you just work straight lateral and don't go cranial enough, you risk doing an inadequate decompression because you can leave some of this tip of the SAP. You can kind of see that in this upper right picture here. The IAP is obviously shingled down over the SAP. And if you don't go all the way to the top of the SAP, you could leave some of this bone right in the foramen and have an inadequate decompression. So what I'm doing is I'm basically removing that caudal aspect of the lamina down to the IAP and looking for the SAP below. And once I find that SAP, I work cranially with my decompression in order to take it till I get to the cranial aspect of the SAP. I'm still cautious about going too far laterally because you don't want to remove too much of the facet joint and destabilize the patient. One thing that you can do is I do this on preoperative. I plan preoperatively on the MRI or the CT scan, and I get an idea of how many millimeters of bone I'm going to remove. So say it's 7 millimeters of bone from the start of the facet joint, or 5 millimeters. And you can estimate based on, say, the size of the drill tip. I know that my drill tip is 4.5 millimeters. So I know that I've taken, the diameter of 1.5 of those, for instance, then that's about how much bone I'm going to want to take. And you can always take more, obviously, you can't put it back. So I'm cautious with how much I take initially. So once you've taken down the IAP, you're looking at the SAP below it, then you're going to thin out the SAP with your burr. And I thin it way, way down. And then I take that last little bit of it with the kerrison, because what's right underneath this is going to be the exiting nerve root. So this is kind of what it looks like as I'm working. I've thinned it down. Here's some kerrison bites. And once you evacuate all these little pieces of bone, underneath it, you get this really beautiful view of the neural elements below. So just to get you oriented here, what we're looking at is, this is the dura. This is the thecal sac. Over it is obviously a little bit of ligamentum flavum, which if you're just doing a foraminotomy, I don't really remove any of the ligamentum, but it can give you a better view of the thecal sac below. Here's a little bit epidural fat. And then exiting is the left C8 nerve root in this case. And you can see it's just like a really beautiful view. Oftentimes there's a little membrane over the top of this that has that epidural venous plexus in it. And that can bleed, but fortunately, as I said, because of the fluid pressure, it doesn't tend to be particularly bothersome. You can always use, a dilute thrombin solution and or your bipolar cautery in order to take care of that. But once you remove that, you get this really nice view of the neural elements underneath. On the right here, you're going to have the left-sided T1 pedicle. And then out of screen over here, you're going to have the C7 pedicle. And again, obviously in between is where the foramen is. Now, what you can do now is investigate underneath the nerve. And if there is a disc herniation, like in this patient, you can very nicely retract the nerve out of the way and very safely remove that ventral disc herniation. Kind of the move that I use for that, because your working cannula has to remain docked up on the posterior elements, is I insert the pituitary closed, retract the nerve out of the way, and then you can open the pituitary or whichever instrument you want in a safe manner and remove that disc material. Again, unlike the lumbar spine where you're docked at the floor of the canal, you can never really do that with your working cannula in these cases because there's no space. And so you're always, it's almost like a one-man band. You're kind of perching yourself up on the lamina or the facet joint, and then working down with your instruments within the canal and within the foramen. Once you've done that, you can, confirm that you're done. And so you can very easily, retract the nerve up and down, investigate the disc space, palpate, and make sure that the nerve is free and mobile at this point. And then the next thing, which is my favorite thing about these cases, is turning the endoscope around and looking back out the foramen, which is just such a cool out-of-body experience, and a way that there's no other way to see this anatomy other than with the endoscope. And so I always, at the end of the case, I'll turn that scope around and look back out the other way. And what you can see is this is the nerve exiting. This is the one pedicle, and this is the other pedicle. And you can even, as you go down, kind of see out past the lateral borders of them as they slope away. And you can be very confident that you're done with your decompression. When I used to do these through a metrics tube, which is how I did it before, I would try to feel, put a ball tip out there and say, oh, I think I feel the lateral aspect of the pedicles. But here you can directly see them, which gives me a lot more confidence that I'm done. This schematic here just shows the kind of bounds of the bony resection that you're trying to do here. So basically starting from the start of the lateral mass and facet joint, going out to the lateral border of the pedicle. And if you remove this little trapezoid of bone, you're not removing anywhere near 50% of the facet joint, but you're unroofing the canal and giving your nerve a lot more space there. And this is just another view kind of looking out that foramen. This is from a different case, but it gives you just a good idea of the fact that you can see this nerve is decompressed. It is going out the foramen. I always take some fluoro shots at the end of the case, obviously just to confirm I was everywhere where I thought I was. And so you can see I could put a ball tip up to the undersurface of this pedicle and a ball tip down to the top surface of this pedicle, confirming that I'm pedicle to pedicle decompressed. And then you can put the ball tip even all the way out the foramen and see that the tip of this ball tip is out past the lateral border of the pedicles. And then for my discectomy cases, I always save the disc material. One, because I send the patients a picture of this so they can see what was torturing them. And two, it helps me correlate with the preoperative MRI and have an idea that, I've removed what I expected to be there. This patient had complete resolution of his pain. His weakness also resolved. I saw him back like a year or two later because he brought his wife to see me for something else. And it was pretty cool to be able to see him and see how his incision had healed up so beautifully. Pretty incredible to be able to do this kind of work through such a minimally invasive technique. And then just checking my work, a handful of times, some of these patients have needed additional imaging for other things, which has been a nice way for me to be able to check my work. And so these are two different cases. This is a right-sided foraminotomy I did. This is a left-sided foraminotomy I did. And you can see that really I've removed exactly kind of that trapezoid of bone that I'd have intended to in both cases, which really opens up the foramina, but preserves the facet joint. And you can see that I'm able to undercut here, which has allowed me to really maximize my foraminal dimensions without taking as much facet joint. How about the learning curve? I alluded to this earlier. Dr. Hofstetter and I and our teams published the two of our learning curves for posterior cervical foraminotomy. And in keeping with the lumbar learning curve literature, what we found was that the learning curve for these cases was much more about operative time than anything else. So our very first cases, we were still effective and safe at doing so, but we were slower, which is okay because our patients were still getting relief and we were not having higher levels of complications. It was just taking us a little bit longer. But over time, what you could see is we got faster over time. My learning curve is there on the left. My plateau or my first kind of boost as far as operative time goes came after my 8th case. Dr. Hofstetter's came after his 29th case. And the interesting thing here, though, is that Dr. Hofstetter started doing these cases much earlier in his endoscopic experience than I did. So I think he only did 5 lumbar cases before he was brave enough to do a cervical case. Whereas I did 50 lumbar cases, but yeah, you're a beast. I did 50 lumbar cases before I did my first cervical case. So I don't think this is because I'm a much better spine surgeon than Dr. Hofstetter, but I think it shows that the more experience you have, it's just the faster you get. Dr. Hofstetter also had a second kind of bump in his speed around the 50th case or so. But again, our patients did really nicely from a clinical perspective. How about Duratomy management? This is a common question that we get both for the cervical and lumbar spine. I'm fortunate that I don't have extensive experience in cervical durotomies. This is video and a still photo from the only one that I've had, knock wood. This was a case of a gentleman, an older gentleman who had very severe bony stenosis in his foramen. And I got a durotomy right kind of at the shoulder of the nerve root in the nerve root sleeve. Probably when I was taking down that last little bit of the SAP, I think potentially with the kerosene, hard to know for sure. What I did is I just finished the case as normal, decompressed the nerve, and then kind of inspected what I had going on there. And what you can see is these are the rootlets here. This is not dura. This is dura over here. The rootlets are kind of on the right side. And when I let go of the fluid pressure, they are kind of herniating upward a little bit. This is not something that was really amenable to any sort of direct repair, even if you were doing this open or through a tube. You know, it was not some sort of linear rent that you could fix. I opted to do a collagen matrix onlay graft. So I just cut a little piece of collagen matrix and inserted it down there to kind of, place some additional pressure on top of there. And then I removed my endoscope and closed as I normally would. I don't leave drains in any of these cases, and I didn't leave one here. I allowed the patient to ambulate normally after surgery. He had no symptoms at any point, either immediately postoperatively or at any point during follow-up of a spinal fluid headache or any other kind of spinal fluid leak type symptoms. And he loved it. He had complete resolution of his arm pain, et cetera. So this is certainly an option here, similar to our lumbar spine literature. Fortunately, with these endoscopic cases, there's not a lot of dead space. And so, things like a Duragen or collagen matrix, inlay or onlay graft can be very beneficial. We published the inlay graft technique in the lumbar spine recently. So that's in the literature now if you're curious to see that. But long story short, I think that endoscopic posterior cervical foraminotomy is a really wonderful procedure that really showcases the benefits of endoscopic spine surgery, especially as compared to either open techniques or, ACDF or other kinds of surgeries in the neck. Any questions for me about any of that?
Hey, Peter, it's Sanjay here. That was a great talk. We've seen a lot of cervical stuff, and actually they did that lab a little bit before you, so I think that was super helpful to hear your talk. What are your tricks and tips for lower cervical spine? Because, obviously C6, 7, 7, 1 are, obviously a little bit more difficult to get to from the front, and, with bigger patients, they have their challenges. And, a paracentral disc at 7-1 is almost a perfect case for this. But if you're not using navigation or intraop CT, the intraoperative fluoroscopy can get a little bit challenging to get to your spot. So,
yep.
For me, I know my answer is just using an AP for most of it. Do you have any other tips? Obliquing the C-arm, things like this. I'm wondering if you have any other thoughts.
So I've just come to terms in those cases with the fact that I'm going to have to do the whole thing on the AP. And so my hospital where I did all these cases, we just recently, like in the last couple of weeks, got like 3D imaging capabilities and navigation. So I did all of these cases, and I have done all of these cases on fluoro alone. And what I do is I'm really careful about that AP X-ray. So, the day before surgery, the night before surgery, when I'm planning my cases, I'm counting down from the top on the pre-op X-rays. I'm counting up from the bottom. I'm drawing arrows and packs, ensuring that I know where I'm looking. And usually as long as you're as long as you're careful on the AP X-ray, I can always see what I want to see. I don't spend as much time trying to see it on the lateral because a lot of the times you're just never going to do so. But as long as they have, obvious anatomy, a rib at T1, usually you can see there. It is important to get a really good end plate view though, because you can be tricked if you don't have a good AP at that level. So it's not just a straight up and down AP, it's an AP with Ferguson, so you can look right down that disc space.
Hey, Peter, again, thank you for that amazing talk. Just in line with that answer of yours, when you do AP, and I agree, without navigation, the only thing you have is AP. For a foraminotomy, I typically come in a little bit steeper, right? Because then you can avoid a little bit more drilling. For a ULBD, I come more in line between the spinous processes. What is your, and I find this hard on AP X-ray sometimes to get that. Do you have any tricks for us? How to get the, like the medial pedicle line, that's I think everybody agrees on that. And then, where rostrocaudal you make an incision with those AP X-ray landmarks that you have.
Yeah, so I know you like to go a little bit caudal to cranial in your trajectory. And I think that makes sense, especially if you're doing, ULBD or something, because you're undercutting. I like to go for my foraminotomies straight in line with the disc space. And the reason is because if I'm straight in line, I find that it's easier to look both up and see the pedicle above and down and see the pedicle below. Whereas if you're angling upward, it might be a little bit harder to look down and see that pedicle below. And so what I'm doing is I'm just trying to find the perfect angle on my X-ray, on my AP X-ray, that makes those end plates line up at that disc level. And then I make a mark, on the skin at the point that overlies that, which should be a trajectory right in line with the disc space. And I find that that's been, useful markers for me.
Yeah, no, I think you're totally right. I think if you go to far caudal, then the inferior pedicle blocks your view. So I think you're absolutely right. There's the fine line of tilting, going a little bit more caudal to save some drilling of the lamina versus being too steep and the pedicle blocks yourself. Now, one little question I had for you with the SAP resection, that is, I've heard so many different opinions, and I want to poll here in the room too. Some people absolutely like you, and I do the same as you do, that you go all the way to the tip of the SAP to resect it. But I've heard from a lot of people that the stenosis is most likely right where the disc crosses the uncovertebral joint, or the nerve crosses the uncovertebral joint, and you don't have to go all the way up to the tip of the SAP. But I do the same as you do. So we'll poll right now. So Peter, Derman, and we like to do the SAP to the top. Who likes to go all the way to the top, or who just drills right dorsal to the nerve root with those? So dorsal to the nerve root only. Okay, anybody else? Dorsal to the nerve root, not to the top of the SAP, and top of the SAP. Okay, Albert, that's maybe something we should also study, as a little, because, we don't know, that's easy. It's a push of a button and we can study that.
Peter, that was a great talk. A quick question for you about, the indications. I mean, at what point do you decide, okay, this is too many levels? Will you only do one level, or is 2 the max, or what goes through your head when you're trying to figure out which patient's the ideal candidate? I know we talked about the soft disc, 1 level, that's easy. What about, there's 2 levels of foraminal stenosis on one side. Do you think about a 2-level disc replacement, or do you think about a 2-level foraminotomy?
Yeah, if I can, I try to narrow it down. And usually in somebody with radiculopathy, they're going to have one symptomatic level. Usually they don't become symptomatic from multiple levels at the same time, but not always. And sometimes you can't parse it out. I do, send patients for like selective nerve root blocks to really try to figure out what level this is coming from. And occasionally I'll send them for an EMG, which can sometimes be helpful too. But there are scenarios in which, I haven't been able to really distinguish. And so in those settings, I will do, multi-level. I've never done 3 levels, but I've done 2 levels. I've done bilateral before. But if I can, I try to limit it to 1.
So, hey, Peter, it's John. Question, are you using neuromonitoring for these cervical cases?
Good question. I do use neuromonitoring. I'm not aware of any hard literature saying that you have to, but we're all held to the local standard of care. And certainly for cervical cases in the market where I work, most people are doing monitoring.
And could you just speak to some of the changes you might see if you have like cold irrigation versus your pressure is too high?
Yeah.
Irrigation management for cervical spine?
Yeah, so I'm using SSEPs, EMGs, and motors for my cervical cases. Fortunately, I have never seen any negative, neuromonitoring findings. And we don't, and so I have never seen, fortunately, my signals go down, but it's not infrequent that the motors will actually improve. So like I did one of these on Thursday afternoon, and the guy had a C7 radic, and his triceps motors were lower at the start of the case and actually improved over the course of the case, which doesn't always happen. But when it does, it gives me that kind of added reassurance that, I've successfully decompressed the nerve.
Peter, Mark Mahan, nice talk. It's good to see you. So there's two things I would love to emphasize, right? You talked about use of motors. It's really nice, as you say, sometimes to be able to see the response, but it's also nice sometimes what I'll do is, and I'll dictate in my operative note, I'll turn the bipolar stimulation way down to like 2 or 5, and then I'll stimulate the ventral side of the root, see the pattern that's there, and I'll document correctly and say like, I was operating at 6, 7, I stimulated the ventral root, I saw, response in the triceps on my motors.
I like that.
It's just a nice way of confirming it. And the other one is, I think this was a question that was brought up earlier, which was the bony stenosis, bony foramen osteophytes. My personal experience, and I think you were commenting on that, is that sort of that medial to lateral trajectory allows you to compress dorsally, and you can really create some space that sometimes you don't really need to resect those ventral osteophytes, the uncinate osteophytes, just by creating space dorsal to the root as you work further laterally, as you work deeper.
Yep.
Do you have any comments on that, the question of ventral osteophytes?
Yeah, I'm not retracting the root out of the way and drilling out ventral osteophytes from the back. Somebody correct me if I'm wrong, but I don't think there's a really good, safe way of doing that. But I have found that in the vast majority of the cases, if you just decompress them dorsally, that's all that they need. But I counsel my patients. I say, hey, listen, you've got some tightness from the back, you've got some tightness from the front. The vast majority of the cases, if I open it up, that's all you need. But the key here is that we don't burn any bridges. So if I do this and you happen to still have symptoms, which knock wood is a rare occurrence, you're still a candidate for either a disc replacement, if you were a disc replacement candidate before, or an ACDF, if that was the only other option.
Yeah, Peter, I agree with you. I think going for these ventral osteophytes is, if possible, you can actually, with the diamond drill bit, you can go straight into underneath the nerve root, ventral to the posterior longeal ligament, and then sort of being protected by the ligament, go ventral to the nerve root. That's feasible. For these cases, I always use monitoring, but there's a lot of irritation, and people almost always have paresthesias afterwards. So I totally concur with you. I think if the ventral pathology is so severe, then a ventral approach is beneficial.
I still will, I will do foraminotomy if it's ventral. And all of the ones I've done, I've only had to reoperate on one who I ended up doing an ACDF on. But, we're talking about very low single digits number of cases so far. If you look at the comparative literature, looking at ACDF versus disc replacement versus foraminotomy, not necessarily endoscopic foraminotomy, but, foraminotomy in general, they all have very similar reoperation rates over time. And they have all very similar, clinical outcomes. I like foraminotomy endoscopic because it's the least invasive option. And the key is, what is the reoperation? So foraminotomy, the reoperation, it's like 2% per year, is an index level operation. So it's either converting it to a disc replacement or a fusion. Whereas like if you do an ACDF, the next operation is usually another fusion at the level above or below. So, even though maybe overall the reoperation rate is the same, again, you haven't burnt any bridges and you're not starting them down that path.
Thank you again, Peter. That was a great talk.